Hi, everyone. This is Ellen Avery, the medical advisor for the Ketogenic Diet with Nutritia. Thank you all for joining us today for our webinar. We are very happy that you could join us for our last webinar in our Keto University series. But first, I'd like to give you a little bit of background for the series that we've been having. This has been a live event in the past, but of course, given the situation, we have moved this to a series of webinars. We have had one webinar every other week that started in the middle of May and is now going until today in September. We have had 10 webinars that have been led by a series of experts, and today we have Zahava Turner with us. So a little bit of background on Zahava. She is a dietitian with a specialty in pediatrics who has been working at the Johns Hopkins Hospital in Baltimore, Maryland since 2005. She received her Bachelor of Science degree and completed her dietetic internship at Queens College, CUNY in New York with an emphasis in clinical nutrition, and worked for 2 years as a pediatric dietitian at Schneider's Children's Hospital. Zahava specializes in using the ketogenic diet for children with epilepsy and has spoken both nationally and internationally at several conferences on the ketogenic diet and modified Atkins diet for epilepsy. She is a co-author of more than 20 publications and also the widely referenced Ketogenic Diets 6th edition, which is also known to me as the Purple Book. So throughout this presentation, you will have an opportunity to ask questions via the Q&A box on the bottom of your screen. If you don't see it, you can click the 3 little dots and hit Q&A box and put those questions in the Q&A box, and we'll ask those questions of Zahava at the end of the session. We will also be asking for your feedback via a survey at the end of the session. We would appreciate that feedback, so be prepared to answer those questions when we're done. Without any further ado, I'm going to be passing controls to Zahava so that we can get started with today's presentation.
Hi, everybody. Thank you so much, Ellen, for introduction and for inviting me to speak today. I really appreciate everybody taking time out of their busy days to come and listen to this talk. So what I'm going to be speaking to everybody is about the classical ketogenic diet for epilepsy. You will see it referred to as CKD just on a bunch of different slides. And I really like to talk about the history of the diet, which I find fascinating. I hope you will as well, and discuss some of the research that is out there. I'd also like we're going to talk about the overview of what the classical ketogenic diet is and review the other diets that have come out that are similar to the ketogenic diet and what people are doing as other variations of diets. I will discuss how to calculate the classical ketogenic diet and identify helpful tips on monitoring patients on the ketogenic diet. Now, I used to give this talk, I still do, a lot to residents, doctors, nurses in the hospital, all to, explain what the ketogenic diet is for epilepsy. And I've had many patients over the years, and I've spoken, many times about the diet, but I would say within the past 4 or 5 years, my talks have really changed. And the reason is when I spoke about it a couple of years ago, nobody really knew what the ketogenic diet was. So, I would say I'm talking about the classical ketogenic diet for epilepsy and, give a talk on that. Nowadays, I would say within the past couple of years, and especially the past 2 years alone, the word ketogenic diet has exploded. If you Google ketogenic diet, just plain, you will get over 44 million results, hits, whatever, I don't know the term for it, but you will get a lot of results. I'm not even saying millions, 44 million. Of those 44 million, 2% of it is about epilepsy. Now, if you would have done that search a couple of years ago, most of the hits would all have been about epilepsy. So I think it's a confusing time when so many people have heard about the ketogenic diet and so many people know people like your aunt, your friend, your neighbor are all doing the ketogenic diet. And what really hit home to me was when one of my best friends called me up. She goes, could you please put me on the ketogenic diet? I need to lose a lot of weight. I said, you know what, just go online and do what we did on Atkins diet 10 years ago. And we were out with a bunch of friends a couple of days later, and she goes, even the experts at Hava can't teach me about the ketogenic diet. I'm like, I don't think you understand. You don't want to do what I teach and the ketogenic diet for epilepsy. So there's really, I think our teaching has to change what the ketogenic diet is for epilepsy versus what the diet is for kids. So let's talk about the history of the diet. I will go a little bit more into detail about this, but really we do trace it all the way back to the New Testament, to Hippocrates, all the way up to 1994, which is a very special date in the keto world. So, in a bunch of places, Hippocrates, a philosopher, Galen, it's written, and in the New Testament, somebody has epilepsy. What should we do? Fasting and prayer, abstinence from food and water. And that was the means of treatment for epilepsy for many, many, many years. Now, prayer, obviously for many years, but fasting and prayer obviously worked to some degree, which is why it was just what was done to treat epilepsy. There was a report in the 1800s coming out of France about prolonged periods of fasting and basically how long should a child fast until the child can stand it. And it was a very popular diet back then, even being written up as fasting as an epilepsy cure. And then it wasn't until the 1920s where actually Dr. Wilder, who's really the person who created the ketogenic diet, created this low-carb, high-fat diet to actually mimic fasting. And for years, that's what we thought this diet actually was. When you switch around what you eat by instead of eating carbohydrates and eating fats as your main source of fuel, then that's the same way as tricking your body into thinking it's fasting. This was a highly popular diet and used all over the United States in centers, not in every state, but in a bunch of different centers for many, many years. And, up until, like the 1990s, this is like a map of who was doing the diet around the world in the 1990s. And you see, North America is pretty much covered, but not every hospital was doing it, but pretty much it was fairly available. When I trained in the early 2000s, I didn't even learn about it. So it was still not as popular, but, still being done. What happened was a lot of medications were introduced. And with each medication created to be a cure for epilepsy, medications were always being used first. It wasn't until like about 1994 where the Charlie Foundation was created, and that's Charlie now. But in 1994, he was about a 4-year-old boy, and he had very bad epilepsy, and he was on many, many medications, and the doctors told him that there was no hope. So his father went to the library back then and read about the ketogenic diet. His doctor told him not to go onto it, that it's an awful diet, nobody could sustain it, the food is awful. So he called Dr. John Freeman, who was the head of neurology at Johns Hopkins Hospital, and he said, come on over. And Charlie was one of those boys or children who were seizure-free right away. So his father started a foundation. He also was a movie producer, so that helped. And he created this foundation, but also came out with a fantastic movie called First Do No Harm and went on Dateline. And that's what really, and put the diet back on the map, that people were starting to think about it and do it. And they came up with a lot of resources and they funded research, which is huge. To actually get the diet and tell parents that this isn't the worst thing, it's actually the great thing. And they wish they would have been told about the diet a lot earlier. So then this is a map from 2018, and I think Dr. Kossoff is actually working on an even more updated map but to show where the diet is now and basically being practiced pretty much all over the world, except for some parts of South America and of Africa. And one of Dr. Kossoff's goal is to fill in the entire world with access to the ketogenic diet. But, and it's getting there after all these conferences that we have, international conferences. Hopefully more and more places will be able to provide it. Okay, so, I would say 5 years ago, 8 years ago, the question is, what is the research? Is there research? Now, there is a lot of research. And as you can see from the graph, that how much research is actually being published, pretty much, I would say almost daily. Up until the mid-90s, there was maybe 1 to 2 studies a year. Now it's, daily, if not weekly. Many, many, many papers being published on the ketogenic diet, different aspects of it, and really cool papers coming out there. Up until about 10 years ago, the question always was, what about randomization? You can't, none of these studies are really considered the gold standard because there is no double-blind, studies being published. So there were 2 studies that came out to kind of really show that it can be done. Because as we know, it's very hard to do a randomized study with diets. So, how would you go about doing that? And both the group at Hopkins in 2009 and the group from London both came up with 2 very different but ways to show that research can be done and to show that the diet works, which was kind of the main purpose of these 2 studies. So the Hopkins study was very interesting. They admitted a whole bunch. Well, I could tell you how. They admitted kids to the hospital, and they admitted 20 children. I'm sorry, and they fasted them for 36 hours, and then everybody was given the ketogenic diet. One group was given the ketogenic diet with 60 grams of glucose per day. And the other group was given the ketogenic diet with 60 grams of saccharin per day. And then they did a flush out period and then switched. So really what we learned from this study is that, it was double blinded. So nobody knew if they were given the glucose or the saccharin. And it was able to be, studied and done. The end result was that both groups did the same, which is good to show that the diet works. But the ketosis wasn't broken with the group with the saccharin. With the group with the glucose, which means that it just probably wasn't enough glucose to break ketosis. But if it would be done with a higher amount or different amounts, then it could possibly break ketosis, and we could see. But in both groups, both of them had the same efficacy. Maybe the group with the saccharin leaned towards a higher reduction in seizures. The other study was the group out of London, where they randomly assigned who did the ketogenic diet versus the MCT oil diet, and then it got switched. So also looking at the difference between the 2 diets, and their first group, actually, they either did no treatment versus starting the diet. But again, the same thing, showing that you can randomize and you can, this study wasn't blinded, but how it can be done, and that how the research, with the end result of how many people were seizure-free is very similar in all the studies. And that's kind of, the main thing that I want to drive home, is that the diet does work, and you see that greater than 50% have that greater than 50% response rate, which is what we're looking for. In 2009, there was an international guidelines that were established It's called the Optimal Clinical Management of Children Receiving the Ketogenic Diet. And it was an international group that got together to come up with which patients should go on the ketogenic diet, supplements, and all things that I'll talk about as well. But it's an excellent paper to look at. And actually, this is the one to really look at now. It was revised in 2018 to look at, and if you're starting a patient on the ketogenic diet, just to see what everybody internationally, so across the board, what people are recommending versus admitting patients, not admitting patients, fasting patients, not fasting patients. So we want to, so everybody could be on board, and it's an excellent resource if you're starting a patient on the ketogenic diet. Okay, so now that I spoke about some of the background, let's talk about really the nitty-gritty of what the ketogenic diet is. Now, I always like to say for the first word that it's a high-fat diet, because that's pretty much what it is. It's 80 to 90% of total calories are going to come from fat. Now, it could be many different fat sources, but really you as the provider and the parent and whoever the physician has to understand how high in fat this diet is. When people, again, think about the ketogenic diet, they think low carb. Now, yes, this diet is very low carb, but people are like, big deal, I could do low carb. I've tried cauliflower rice. I've tried cauliflower pizza. It's not the same thing. We're doing 80 to 90% of total calories are coming from fat. So I really have to stress that to parents to understand how much fat is on this diet. Now, I will show you soon, like there are ways to make the diet look normal, taste normal, and everything. And I don't like to focus on any negative or what's bad, but everybody has to understand that how high the fat is on this diet. Now, the goal is to meet their protein needs. So whatever the DRI is for that patient, for the kids, we have to meet those needs, which then results in a very, very low carbohydrate diet. All the foods are weighed on a gram scale, and that's in the picture there. I would say I would just have to update the picture. Instead of a binder, I would take a picture of an iPad or a computer screen, because now everybody does their recipes and everything online. But, pretty much for years, that's what a parent's table looked like. You had your recipes, your scale, your heavy whipping cream, your macadamia nuts, your butter, and then some medicines. That's either the vitamins or the medicines, but that's pretty much what a day in the life of a keto mom could look like. Recipes nowadays are all prepared. I would say 90% of recipes are all prepared using a computer program. Now, again, to drive the point home, a typical American diet, we eat a lot of carbohydrates. There's nothing wrong with carbohydrates, which is another thing that I also have to emphasize, because I am pretty pro-fat, but there's nothing wrong with carbohydrates. If you eat healthy carbohydrates, your proteins and your fat, that's what a classical American diet should look like. So what is a classical ketogenic diet? Flipping that blue color around that looks like fat, that represents the fat. And that is what a typical diet looks like on a pie chart. So very, very different than what we're used to eating as Americans. Very different from what the kids are used to eating. And now their body is going to be taking in all the fat and burning that for energy, which is also a change to their metabolism. So a change to what they're eating, what they're seeing, and how their body's reacting to it. So a lot of changes that go on. Now, this is taken from that international paper that I was telling you about. And everybody got together who should get placed on the ketogenic diet. And table 1 is listed as reports, like either case studies or different kinds of papers that showed either a greater than 70% than average of the 50% response rate. So the average is 50%, so this showed a greater than response rate. And a lot of symptoms that we see are Dravet syndrome, myoclonic atonic seizures, or otherwise pronounced sometimes as DOSA syndrome, something called GLUT1, which is glucose transporter protein deficiency syndrome, FIRES, febrile infection-related epilepsy syndrome, Now, not a syndrome, but something very interesting is kids that are solely formula fed, either babies or G-tube fed, do very well on the diet. Infantile spasms, and then a bunch of other tuberous sclerosis complex. And then table 2 are just like case reports of patients that have done well, and you could consider putting these patients on the ketogenic diet. From the case reports, I do see a lot of Lennox-Gastaut syndrome, Rett syndrome, probably a lot more, but those 2 are jumping out at me right now. So this is the list that with different types of epilepsy, which is interesting because there are many different types of epilepsies and they're all kind of working in different ways. I don't, obviously know, but, who the diet works for better versus it doesn't. We used to say everybody should try the diet, but we do know now a little bit better who might do better. I just said that a couple of times, but we do know which kind of syndromes and which kinds of epilepsy types have a better chance of doing better is kind of what I'm trying to say. The typical way to think about it is a patient who fails traditional anticonvulsant therapy. So if you, as a provider or a parent, have started on one medication and your child is completely doing great and fine, there's no reason to start the ketogenic diet. It's for patients who are on their 3rd medications and nothing has changed. When we really start to consider, I'd like to start considering the diet, maybe by this, if you're thinking about the 2nd drug that's not working, but really after they fail regular medications. Some patients who are poor candidates for epilepsy surgery, but they know they need surgery. Sometimes the diet can help. We have done all ages, starting from infants all the way through senior citizens. I don't know if that's the correct way of saying that, but through adulthood. And the average time on the diet is 1 to 2 years. So for kids, we tell them that from the beginning, that they're going to be on this diet for about 2 years. And that is based off of medication. So if a patient were to start a first medication, then they would, and the seizures would go away, they typically would be on the diet for 2 years. So this is to mimic that medications. Now, there's some syndromes where they might be on it for life, something called GLUT1 deficiency, because glucose is not being transported through the brain, then, they would need they would need this diet for life. Other situations, and there's many studies and looking at different syndromes of maybe only being on the diet for 6 months, maybe 2 to 3 months. So a lot of really cool research is coming out now about how long to stay on the diet and cool stuff that will be coming out hopefully. So there are contraindications. So not everybody could go on the ketogenic diet. Sometimes when you go online, people will say the ketogenic diet's for everyone, but it's not. For the doctor, when they do all the genetic testing, you want to make sure they don't have any kinds of fat absorption, genetic disease. But for the dietitian, my main issue would be to make sure that they can maintain adequate nutrition. If they can't, then that would be a reason not to go on a diet. So, in some cases, it's really where parents have been going to feeding clinics, their children have not been eating so well. And then, they come to us to start the diet and we're like, your child's very thin, not eating well. Let's discuss a feeding tube. Not that they can't eat during the day, but maybe we'll need some extra nutrition at night. Because if the whole treatment is a diet and they can't get the diet in, then it won't work. And it's not an easy diet, obviously. So if they're not taking regular foods, how would they necessarily take in the ketogenic diet? Parent or caregiver non-compliance, that's pretty huge. So these would all be different reasons why you shouldn't use the ketogenic diet. Now, so what is it? What does it look like? So the basic structure of an American ketogenic diet consists of heavy whipping cream, of fats. So the fat could be butter, mayo, or oil. It could be all three. It could be one. It depends on the recipe. A protein or a fruit or a vegetable. So a typical menu, because everything is so specific to the gram. We weigh out every single food. So we would weigh out 40 grams of heavy whipping cream on a gram scale, and that 21 grams of fats, and that could be 21 grams of butter or 21 grams of mayonnaise, something like that, 24 grams of chicken, 11 grams of broccoli, and 12 grams of lettuce. And that is what is a typical, easy, I would say, recipe where families have the chicken, have the vegetable at home, heavy whipping cream. Heavy whipping cream was designed to replace milk. So American kids are big milk drinkers. What could we give them to replace that milk? And heavy whipping cream has been used for years. It obviously doesn't taste like milk, but there's ways to doctor it up and make it taste like milk. And it could give 50% of the fat that's required can be given just through the heavy cream. So if kids like it and they like milk, they usually could drink this. We have a lot of tips of how to incorporate it, but typically kids just drink it. So these are pictures actually from parents of kids on the diet through Hopkins, very creative parents. And, sometimes I show this to families and it actually scares them off, because if you're not used to cooking and baking beforehand, it's a little overwhelming. But they see a recipe with sausage and cabbage or sausage and sauerkraut. They're like, oh, I could do that. And then other families come in already with all these million recipes, ideas, and they're the ones that are creating these donuts and these soups and these muffins and these raspberry white chocolate cups. So like an easier recipe would be like that chicken recipe that I said, with a low-carb tortilla and some avocado and mayo, like on the bottom left. But it really is up to the level of the parent, of their cooking level, coming in to start the diet. And, sometimes I could see how it could be overwhelming to want to create this for your children, but have been doing takeout for the past 2 years. So it's just something that we have to discuss and, discuss the very simple, tuna fish meal or chicken salad meal or egg meal. I'm showing these foods just to show you how pretty and how nice regular parents, not chefs, have created really cool recipes. So besides for foods, we do have kids that need to go on formulas. Either they drink it or they have it through their G-tubes. And these are the formulas that are available. So KetoCal has a full line of formula through Nutricia, and of different ratios. So down to the 2.5 to 1 ratio, all the way up to the 4 to 1 ratio. And there's powders and liquids. And same thing with Keto V. They have a 3 to 1 and also 4 to 1 and a 4 to 1 peptide formula. And then those two formulas, KetoCal and Keto V, are both milk-based formulas. So if a child is coming on any regular standard pediatric formula and you want to switch them over, then you would switch them to either one of these milk-based formulas. RCF is made by Abbott. It's called Ross Carbohydrate Free. It's a soy-based formula. It needs to be doctored up with fat, carbs, and vitamins. A new formula on the market is Keto Peptide from Functional Formularies. It's a blended food formula. And these are the main formulas out on the market. Sometimes formulas need to be doctored up by either adding more fat or by adding more carbs and adding more protein, just like you would in in any kind of formula situation. Your emulsified fats, like your Liquigen MCT emulsified fat, is just a great way for tube feed so that it doesn't separate out. Then you have your protein, your powders for your carbohydrates, and for your protein, either beta protein or complete amino acid mix. Now, the diet is deficient in a lot of vitamins and minerals, not from the formulas. Those have all their vitamins and minerals. They're complete for meeting all the needs for children. But when a child is eating the ketogenic diet, that's when the diet is deficient. And that's because we're taking out carbohydrates. And in the United States, carbohydrates are enriched with all of our B vitamins. So your cereals, your pastas, and your breads are no longer on the diet. So they need to take a low carb or carb-free multivitamin and mineral supplement. Some people do recommend carnitine and selenium. That really is based off of your center, what your center feels strongly about. But you do want to make sure they're meeting all their B vitamins, their calcium, their zinc, their phosphorus, all their trace minerals. Some people add MCT oil, some people add salts. Those are all in addition. But the main thing to add is making sure they're meeting their DRIs for their vitamins and minerals. All right, so almost last part, how to calculate the ketogenic diet. So the ratio is the grams of fat to the protein and carbohydrate combined. So the higher the ratio, the higher amount of fat that's used on the diet. That's in the diet. The typical ratio is 3-to-1, and this is typically what we do at Hopkins. There's many different places that do different ways to start the diet or to keep their child on the diet. So I'm talking about what we do at Hopkins. 3-to-1, we would put a child less than 2 years of age or a compromised patient. 4-to-1 is kind of everybody in between. And this is a great picture from the Charlie Foundation to show the difference in the ratio. The 1-to-1 on the bottom right in green, there's a nice amount of chicken, a nice amount of broccoli, and a little bit of dressing. And that's what I would call pretty much what an adult ketogenic diet for weight loss might look like. On the top left, that's what a lot of the kids are eating for the ketogenic diet. A little bit of chicken, a little bit of broccoli, a lot more mayonnaise, and that is oil in the medicine shooter. So just to show the difference in the fat and the lower in protein and carbohydrates. So how do we estimate calories, protein, and fluid? However you normally calculate that for the child that you are evaluating. DRIs, WHO, Schofield, you could use any of those. There should be no calorie restriction. Whatever calories you deem them to be on, that's what they should go on. Now, once you start to calculate their diet, we use this thing called calories in the dietary unit. So if you look at the 4-to-1 ratio, it has 40 calories per dietary unit. We divide that into their total calories. And then, and then we get from there how many grams of fat per day, how many grams of carbs per day, and how many grams of protein per day, just by figuring out these calculations based on the 4 part of the ratio and the 1. At Hopkins, we admit many families at one time. We have found that through the years that it's been easier on the dietitian and on the doctor because you educate in a class, as well as the families, get to meet each other. We do a 3-day admission, and there's education daily. Some centers measure blood glucose levels. We measure blood glucose levels, Most centers measure blood glucose levels and ketone levels. We do a slow initiation, a 24-hour fast. Then we start at half the calorie strength for 24 hours, and then we advance to full strength. The half strength and the full strength are at their goal ratio. Now, you could use either an eggnog, which is pretty much just liquid eggs and heavy whipping cream, or any kind of ketogenic formula to get to full strength. And if they eat, then we give them full meals for full strength, regular food, for full strength. This is just an example, but pretty much what the 3 days look like when they get admitted to start the diet. There's a doctor's class. There's a nurse. We have a ketogenic nurse who gives a class on side effects. We have parents that have been on the diet that come back in to speak to other parents about their experience. There's a social worker. We have a pharmacist who goes through all their medications. And then a lot of classes by me, how to weigh and measure the foods, how to create recipes online. Can they be transferable to a keto recipe? And just the basics of the diet is kind of where I start. But, reviewing everything in those 3 days. Now, there are side effects to the diet. The main 2, I would say, and actually I just realized I don't have the second one, constipation and reflux. Those would probably be the 2 main side effects. We can see poor growth, osteopenia, osteoporosis, kidney stones. I would say these are more long-term effects. Hyperlipidemia, cholesterol levels, and triglyceride levels do increase. But then for the kids, we watch them and they slowly come down. And vitamin and mineral deficiency if they don't take their vitamins. If they take their vitamins, we do not see that. So we typically follow up. It's really every 3 months throughout the year, but we do see everybody back that first month, and we check the labs at each visit. In that study, in that international paper, the guidelines, it does have recommendations for what to do at follow-ups. We typically would not touch any medications the first month. just to give the diet that time to see that it works. We might be a little bit more on the aggressive side with taking away medications, but that really depends on what's going on. We a lot of times see children coming to see us with 5 to 6 medications. And, one of their main goals right away, besides reduction in seizures, is to get rid of some of those medications. We talk on the phone and email a lot between visits. And we take over their care pretty much, unless they're from out of state, but not, like if they're too far away, if they're drivable in the next state over, fine. But we typically take over. And then I listed all the things that we could check laboratory wise. And we go through it every visit. If they're on the diet already for 18 months, are we continuing this diet? Is there, should we start talking about weaning off the diet? Is the diet working? All these different questions that get asked. How hard is the diet at home? How are they eating the foods? Are they giving you a hard time with every single meal? All of these questions have to be asked. So there's 4 other diets, probably more, but the 4 main other diets that have been created to actually make the ketogenic diet a little bit easier. I would say all kind of working off of the same idea, but can it be done easier? So the modified Atkins diet was also started about 10 years ago to, when you describe the classical ketogenic diet to somebody and you'd say, we get rid of carbs, there's some protein. And one of the moms was like, oh, like the Atkins diet. And so Dr. Costa was like, yes, very similar to that. And that's kind of where that started, before coming in for your admission, cut out your pasta, cut out your breads, read the Atkins book. And the patients were actually doing very well. So it's called the modified Atkins diet because it's not just a low carb, high protein diet, it's also a high fat diet. So that diet, and then the low glycemic index diet, I'm jumping a little ahead of myself, sorry. And then the low glycemic index diet also came out around the same time as the South Beach diet, focusing on low glycemic foods, less than 50, and it allows for more carbohydrates. So you would find foods that are low glycemic index and only eat those, and still eat low carb, but not as low as classical keto or modified Atkins. MCT oil diet was created to replace half the fats pretty much with MCT oil, and that allows for more carbohydrates. And then there's something called the modified ketogenic diet, which is kind of like a low and slow approach. That picture that I showed of the all different ratios, you can maybe start at a 1-to-1 ratio and kind of work your way up to a 4-to-1 ratio, but sometimes you don't even have to get to the 4-to-1. And that's what's very nice about it, because at a 4-to-1 ratio, which is what we classically start everybody on, that's a lot of fat. And it's sometimes hard for people to handle all of that. So by by starting off slow, it helps. Sometimes it's a 1-to-1 ratio is very hard for people. So going to that 2-to-1 is hard. So really there's so many pros and cons to all these diets and what works for that patient and what works for the family. Sometimes people do a combo. They'll do modified Atkins diet, low carb, but modified Atkins diet, and then only give them low glycemic carbohydrates to use in the modified Atkins diet. Some people add MCT oil. So it becomes an artistry of finding what's right for the patient. Can this patient be admitted to the hospital? No, they have 4 other children at home and everybody's on Zoom and nobody could be admitted. So, let's try the modified Atkins diet for a while at home where no admission is necessary. So really it's a discussion between the neurologist, the dietitian, and the family to decide which diet is best. I did want to talk about for a minute that we do have an adult center at Hopkins, and that is the most, I think, the adult side all over the United States is what's growing, kind of how the pediatric side grew 20 years ago. So almost in every single hospital, there's pediatric classical ketogenic diet. If not, where the big center is in your town. But it's not like that for adults. And centers are now popping up all over. And what they do is a modified Atkins diet, 20 grams of carbohydrates per day. They start on vitamins, calcium, vitamin D, seizure calendars, checking ketones, all the similar stuff to the modified Atkins diet. but, it's an adult epileptologist who understands more of adult epilepsies. And it's very important. And adults are looking for diets. And this is probably the most growing part of the diet in epilepsy. And with that, I'd like to summarize. I hope you learned about the ketogenic diet. It does involve time, as you can see with the calculations. I really kind of glossed over it, and especially because we have computer programs now, we're not sitting there doing cross multiplication anymore. But it is difficult. It is time consuming. It's not difficult on the time of the dietitian's part, and it's not difficult from the parents. It's just really learning how to do it. I would say the first month is a huge learning curve, and it's very hard. And then the parents get into the groove of things. Not that it's ever, I don't want to ever make light of it, but it does get easier. It does require a team. I'm very lucky. I have a large team at Hopkins, and I do recommend if you were ever to start the diet, you definitely need at least a physician on your side. But a physician, a nurse, any kind of pharmacy support, case management, or social work are also very helpful. We also have child life in the hospital. So all of these as support, it does require a team. And so the questions are not always being fielded to the dietitian, but each person knows their role and can help the patient with their role. And with that, I say, and here's my references, sorry. And with that, I say thank you very much again to Nutricia. Thank you so much to everybody for joining. Even though I can't see your faces, I do appreciate that you are on, and we spent this hour together. So if anybody has any questions, write them in the Q&A box, and I'm going to hand it over to Ellen to go over the questions.
Thank you, Zahava. You took the words out of my mouth. So thank you. As Zahava said, for those of you who have questions, please feel free to put them in the Q&A box, and we can make sure she answers them for you all. Again, thank you, Zahava, for this fantastic presentation. We will get started with our questions. For those of you who need to get running, feel free to scan the QR code, and that will take you to our SurveyMonkey, or it will also be in the thank you email that you will receive after today's presentation. So I know that I have a question for you, Zahava. What would you say is your biggest challenge when starting patients on the diet?
So my biggest challenge as the dietitian, I really like to make sure that I'm giving them as many resources and as many recipes as I possibly can. And that sometimes is a challenge because you just physically in the 3 days can't give them everything that they need. And I also want to reassure as well as teach. It's a lot of information that I have to give over. So I find that challenging. Again, I'm very lucky because most of these patients before coming in to start the diet are pre-screened through Dr. Kossoff, through, from our center. So I don't have a lot of the challenges that I do know that people do have.
Okay, then a follow-up on that. How many recipes would you normally give a family when they start out? Because I know that's a common challenge clinicians have. They feel like they need to give a family, 25 recipes when they're starting out on the diet. What would you say is a good number of recipes to provide them?
So I definitely give way more. I give about 50 to 60 recipes to the families before they leave. I do think that is on the very high side. And
wow, okay. I was thinking 25 was a lot.
I know. So 20 to 30 is good. I think the most important thing is the tool to how to create recipes, because at this stage, as long as they can create recipes on their own, then that's really all that they need. And I do spend a good 2-hour class teaching families how to create recipes. So what we'll do is we'll create a regular standard recipe with chicken, heavy whipping cream, butter, and a vegetable. Then we'll go online and we'll type in keto. The main question that people always ask me are those keto goldfish, and we'll talk about how that can or cannot be added to their ratio. Sometimes it can, sometimes it can't. We'll just go on different keto websites looking for recipes and then trying to adapt them just teach them how to enter that into the program. Really, I do focus on trying not to do that so much because it's all made with homemade, not homemade, with cups and tablespoons and everything, and we're converting it to grams, and the recipe might not work. But a lot of parents are very creative, and I then take the creative parents' recipes when they share it with me and share it with the other families.
All right. Thank you. And do you know, is for the lab work for the adult patients, is that done the same as frequency as the pediatric patients, or are you familiar with the lab work that Dr. Cervenka does?
Yeah, I'm pretty sure they do it every 3 months, but once they start seeing them every 6 months, I think it switches to them. So it's really every time that they see them, they do labs. They do focus a lot more on the lipid panel, obviously, and send, because adults would have to be medicated as opposed to the kids.
For cholesterol.
For cholesterol, yes, for their lipid panels. Yes, thank you.
Okay. And then in terms of computer programs, you stick with Keto Diet Calculator, I think?
I use the Keto Diet Calculator, yes.
Okay. And is that the only one that you use, or?
No, there's also the Keto Plan, my Keto Planner.
Okay.
Right?
Yeah, my Keto Planner, and then Keto Diet Calculator, or it's just ketodietcalculator.com, I think, and then myketoplanner.com.
.org. No? .com.
Is it .org? I don't know. I just start typing and it comes up.
Yeah, me too.
It's on the Charlie Foundation website. You can find Keto Diet Calculator. It might be .org. But yeah.
And
now
I'm questioning myself.
I know. I can look it up and put it in the chat box for you guys. And do you use, that's the same program that you use for calculating nutrient needs and ratios for patients?
Yes. I predetermine their ratio before they start the diet and their calorie needs, just as a regular nutritional assessment. As a group, we determine, their ratios. It's, again, pretty much based off of age. And then I enter that into the program and how many calories they're going to have at each meal and how many calories they're going to have at each snack. And I base that off of their food records that I get before we start the diets, that I could evaluate like how much they eat and also what their feeding pattern is. Okay.
Thank you. And it is ketodietcalculator.org is the Charlie Foundation one.
Okay.
Somebody is asking a question. Can you talk a little bit about your clinic? I know that there are multiple dietitians. And then is that your only responsibility? Do you have any tips for a dietitian who covers multiple clinics and the hospital system is wanting to add Keto Clinic to the current RD's responsibilities?
Yeah, gotcha. So my response, the way that our Keto Clinic works is we admit patients the first week of every month, and then we have a Keto Clinic one day a month, and we see all the follow-ups. So I'm only seeing follow-ups one day a month, the third Tuesday of the month, and let's say the first week. So that is my dedicated keto time. People are a little bit surprised when they hear that I also cover GI clinic on the weeks that I don't have a keto clinic or a keto admission week. So on those weeks, I'm covering 3 GI clinics and 1 nutrition only clinic. So how do you handle the time and all the questions is an excellent question that I battle with every single day. So it's a lot. It's a lot of keto questions and then a lot of changing your hat and trying to answer just regular GI questions. I do have other dietitians at the hospital. There's Courtney and Jamie, who are both considered keto dietitians as well. If I'm out, they are always there to cover for me. What we switched to recently because of my schedule is I typically just do the admissions and the keto clinic. And then any patient that gets admitted to an inpatient service for whatever reason, it could be neurology or it could be orthopedics, then the other dietitians will see those patients. That has helped me balance some of my time. So, and also these dietitians are able to start an admission if I'm not around. Somebody could always start it. I don't do any, there's no keto weekends call. All the dietitians, we have rotations for the weekends. Everybody can answer any of the calls on about any keto patient that gets admitted. And there was more to that question and I forgot. Ellen, like what else?
How do you have any tips for a dietitian who covers multiple clinics and the hospital wants to add Keto Clinic on top of it?
Oh, listen, I wish I could help you. It's very hard. I told you I'm covering these clinics, plus I'm covering Keto Clinic. What is nice is my manager has given me designated keto time. So that day at Keto Clinic, I will not be asked to cover anything else. And that's the same thing that we do with diabetes clinic. And, so this way you don't have any inpatient responsibilities. You're just in Keto Clinic. You can't be, it's very hard to be pulled, I guess, into many different clinics and then starting a keto clinic as well. So it has to be from your manager speaking to the head of neurology. If they want to start a keto clinic, it has to be designated time that you can't be in different places. You have to have also, besides the time in the clinic, this I know is very hard for everybody, including me, but you need time built in for answering questions. So I don't know where that time comes from and how to add that. But really, when we discuss time management and everything, we discuss, let's say, the 8 hours in clinic, but I do need a good, 2 hours, I think is even too low, but you do need that time to answer questions post-clinic or post-admission. So it's a struggle but hopefully you have a manager who could, work with administration to get you that time.
Yeah, I know that the neurologist has always gone to the clinical manager to say, I need a dietitian for this many hours. And so it's always between the manager and...
Right. It's very hard to just take up on another clinic when you have all these other clinics.
Right. Yeah. What is the meal plan guideline education that you give on the second day of a patient initiation?
What is the meal plan guideline? Let me pull that up. On the second day. Oh, so I go through. It's basically, kind of informally planning out what a meal should look like is kind of what my meal plan guideline means. We could either do it by day, sometimes we do it by month, sometimes we just discuss meals. But after I discuss the basics of the ketogenic diet, we go more into detail of foods and how to use the heavy whipping cream, how to use the butter, how to use the proteins and how to measure everything. So it's kind of like all intertwined. So it's probably like a fancy title for more ways of saying how to build your meals.
Okay, thank you. I had to unmute. What about low-carb products who are on the classic diet in terms of shampoos, lotions, toothpaste, sanitizer, that kind of...
Okay, so when I teach parents, I teach them about anything that goes in your mouth, like toothpaste, chapstick, I guess, mouthwash, medicines, like over-the-counter medicines and stuff. We focus a little bit more on that. I do not focus on shampoos and creams. There is an excellent guide from the Charlie Foundation that is put out that has the list of low-carb over-the-counter products like for the body. I know this is being recorded. I am not a huge believer in that affecting ketosis or affecting the diet. I do, again, believe that anything that goes in your mouth affects it. But my main message to parents is always try the simplest products or the product that they've been using. So, Pantene, whatever. Your baby products are all fine. And your simple shampoos, conditioners, body washes are all fine. Once you're starting to deal with new scents, which I think sometimes affects kids in different ways, and new products, then maybe they might have a reaction to it. But it shouldn't affect ketosis in any way, is my belief. And so that's why I really only teach anything that goes inside their mouths.
Okie dokie. And I think the last question that I see, unless anybody has any other questions, is about stopping the diet. And if a patient needs to start the diet again, how quickly would you resume the diet? Is there any time that you would need to wait before starting the diet again?
Okay, so that's an excellent question that I didn't bring up. So stopping the diet, there's a couple of papers out there. It used to be so slow to wean off the diet. There really is no reason to go slow. So if a patient is either done with the diet because they're been seizure-free for 2 years, or really the diet just hasn't worked, we typically just lower the ratio every week. If you want to go a little slower, you could go every 2 weeks. So pretty much 3 to 1 for 2 weeks, 2 for 1 week, 2 to 1 for 1 week, 1 to 1 for 1 weweek, and then we either say stop weighing and measuring, or we just say come off the diet. To restart the diet, there's no reason not to, there's no anything to wait or not to wait. I have a lot of patients who we restarted the diet a couple of years later. Very few that we weaned them off the diet and then restarted it a couple of weeks later, but sometimes patients have gone into trouble during the wean, and we might say hold tight at the ratio you're at, or go back up to where you were, or something like that. So if we're weaning the diet and they're at a 2 to 1 and we see an increase in seizures, we might say, okay, just hold tight. We might say go back up to the 3 to 1, and then they might stay on the 3 to 1 for another year or another 6 months. Really depending. But we've definitely restarted kids that have come off the diet, let's say 2 years ago, and things are coming back, or things are just not going so well, and we've restarted the diet, sometimes with an admission and sometimes without.
Fantastic. And with that, I don't see any more questions. And so I will tell you thank you, Zahava. Thank you, everyone who has joined our series of webinars. And the survey is back on the screen for anybody who would like to scan the QR code, or in your thank you email, the link will also be there. And thank you all for joining our Keto U webinar series. Thank you, Zahava, for giving us this wonderful presentation. And I look forward to bringing you all more webinars in the future. Have a wonderful day, everybody. Thanks.
Thank you, everybody.